that it showed how people were affected across different areas in terms of COVID experiences. And then that was meant to measure the COVID experiences. But I also modified the Addiction Severity Index interview into a quantitative scale or checklist. And so I was able to check for consistency of this modified tool, which gave us an alpha of 0.95. So the study was approved by the Catholic University of Eastern Africa Ethical Review Board. And then in our country, beyond just the Ethical Review Board, we also seek approval from the National Commission for Research, which the license was granted. And then the county government of Nairobi was also involved in approving the study. And later on, each of the 5 treatment facilities where the study was conducted also approved, and then we got the consent from participants. This data was collected around the end of 2021 when the restrictions of COVID were being lifted, and so people were going back to institutional treatment. So back to the instruments that we used, the EPI. The EPI is a 32-item questionnaire. That's the one that is measuring COVID experiences in terms of work, in terms of economic impact, emotional impact, home life impact, physical impact, and also it assessed some level of positive change. Did people maybe experience positive change during COVID? And then the Addiction Severity Index was modified to a 33 Likert scale measure, and it actually assessed all the 7 domains that were adopted from the interview. And when we look at the results, this is the distribution of the demographic characteristics of the study sample, and I managed to get 100% response because when we look at the education level, we can see quite a good distribution in terms of education. So these people were able to read and process the measurement scales well. And also, I administered the questionnaires one-on-one. And so this was able to eliminate any issues that would arise maybe from incomplete questionnaires or participants who are not willing to continue after getting the consent. So this is the distribution of the demographics. We can see most of the participants here were males, and then in terms of religion, it is Christianity, and that just aligns with the national representation of different religions. Christianity is usually the highest in the country, and most of the participants also had tertiary education. And so on a few descriptive areas or from the scales that we used, these are the experiences that the study captured in terms of COVID, and that's social life, how people reported having been affected in terms of social life. We were able to get these measures in terms of means, and the mean was ranging from 1 to 5. So if we see social life was almost the highest affected with a mean of 1.3, followed by positive impact. So we can see the other areas of life that were affected are work life, home life, physical health impact, emotional health impact. And it was surprising that actually amidst all the disruptions we got, these patients report positive impact as the second highest impact in terms of COVID. And that would maybe would reiterate what I talked earlier in terms of Kenya being a collectivist society. So when these places of treatment closed, possibly people went back to their families, they were able to bond with their families. Possibly that's why people are reporting quite improved experiences in terms of positive impact. And so we did also a comparison in terms of addiction severity. And the graph that we have here, the red shows the severity after COVID. But this data was collected at a single point. So we were asking people to respond to items according to how they perceived their addiction before the COVID outbreak. And then now this data was being collected when COVID was subsiding. So as we can see across all the 7 domains, it indicates after COVID, the severity levels actually went high from the data that we are presenting there. So, we also ran a correlation, and the aim was just to check how did now the COVID experiences, how did experiencing the different COVID experiences affect severity. And we can see the areas that are highlighted, those who, when we checked work-life impact, because different people were laid off from work, the jobs were disrupted. When we check how work-life affected, related with the 7 domains of addiction, of severity, we see a positive correlation between work-life impact and psychiatric status and also the drug status, but not a significant relationship with the other 5. We look at home life also correlating with psychiatric and alcohol status positively. Social life impact of COVID correlating positively with alcohol status and not the rest, also employment status. Then we had the emotional health impact of COVID, which correlated across 5 different, correlated positively across the 5 different domains of severity. And we can look at the positive impact. It did not correlate with, it did not show significant correlation with any of the 7 domains. And finally, we had the physical health impact, because people also got infected, people had physical impact from the COVID experiences. We can see it's also correlating with 5 different domains of our severity measure. And at the end, looking at these results, it actually shows that adverse life experiences like COVID could have some relationship with addiction severity, which then implies that treatment planning in such times should also be adjusted to capture the experiences that people go through when they are going through adverse life experiences. It could be COVID, or it could be another pandemic, or it could be another adverse life event that comes to happen in future. And finally, I want to thank the ICUDDR and the NIDA, which funded this project. It was a small grant, but it went a big step in helping us to make or to get preliminary data in that time. And also the Prevention and Recovery Association of Kenya, which permitted me to administer this survey in their treatment centers. So thank you so much for listening. We'll be taking questions later after the other presenters.
Perfect. Thank you very much, Stephen. That was great. Up next is Charles Orjiakor, is a lecturer in the Department of Psychology, University of Nigeria. He has postgraduate training in clinical and forensic psychology. His research interests include antisocial and offender behaviors, particularly substance use and aggression. He also is interested in health systems and policy research, and has been involved in several projects investigating rule breaking and inefficiencies within health institutions in Nigeria. He's a research associate within the Health Policy Research Group within the University of Nigeria. Charles, up to you.
Good morning, everyone. So my presentation is on community-based approaches in reducing methamphetamine use in Nigeria. And special thanks to my colleagues who helped in carrying out this study. They are not here, but I'm here to speak also on our findings. Special thanks to Joseph Palama, the mentor I was assigned to, based in the US. And very special thanks to ICU, DDR, and NIDA for providing the seed fund. So a bit of a background. Around 2019 to 2022, methamphetamine became very common in Nigeria. Like, it started coming to the notice of people that there is a new drug in town and is disrupting life. So it was made popular by social media, videos of young people with multiple behavioral disorders, and then corporal punishments in communities. And that led me to start to ask what is happening. Particularly the southeastern region of the country was affected more. We saw video excerpts from communities, local communities, taking action against the drug. The actions appeared crude. They were flogging, beating, and people who used the drug. But so much that even the parliament took notice and started looking for ways around the problem. At that point, there was no evidence around Nigeria and methamphetamine, so people were confused on how to respond to the drug. And so I went into an inquiry to ask how widespread is this problem, what actually was it people were using, what was the nature and pattern of use, who is more affected, why were local communities responding to this drug. We had other drug problems. Why was it that methamphetamine was easily spotted and targeted for response by communities? And what was communities actually using? So I did 2 systematic reviews. The first one targeting how widespread is the problem in Nigeria, and the second one, what can communities do? What has other communities around the globe done to respond to methamphetamine problems? And this was for me to make suggestions, possibly policy suggestions to people who were in charge in Nigeria so that they can see what other communities are doing and then find something to respond to the situation. And then more importantly, I did 1 qualitative inquiry. I visited communities that were affected. In some of the regions, I couldn't visit because there were insecurity problems, so I had to use phone interviews, and I interviewed community leaders and users who consented to participate. The systematic review has been published, and some of our key findings are that so community-rooted approaches have potentials in tackling methamphetamine. However, when law enforcement agents acted alone, they had limited success in managing the problem. So several grassroots agents, health advocacy groups, elementary school programs, they can come together and do something. We saw across the US, Australia, and other places that when communities come together, they do powerful things in terms of methamphetamine reduction. From the communities, I interviewed community leaders and users. I found some interesting things. One thing is the ability of the community to detect that something new was in town. They saw a new pattern of behavior among users, something they have not seen. So people harassing their parents, people harassing people around. The crime rose significantly in communities. So they were able to know that they are dealing with a brand new problem. And so the communities mobilized. They mobilized the general leadership and they mobilized the youth. They mobilized their local vigilante groups. Their aim and the strategy there was to identify those who were dealing in the drug and then to cut off their supply routes. They did very interesting things, from strategically placing vigilant eyes in locations into the community, detecting these guys, reporting them to community leaders, communities interacting with themselves, and setting up networks to make sure that they stop dealers from getting into their communities. Experts in diaspora, so people pulled in their kinsmen, who were either lecturers or addiction experts, to come back home during the festive seasons to educate the youths on the dangers of this drug. And then kindreds and clans, so small unit family groups, we are given the responsibility to engage some of the users in trade skills, and sometimes to remove them from the communities where they are trapped in the drug and take them somewhere else where they can learn a trade or a skill, and in that way cut them off from the drug. And it was interesting to notice that, surprisingly, methamphetamine was highly used in rural Nigeria, which was actually surprising. So corporal punishment was there. People were using corporal punishment to deter users. But of course, when they learned, and sometimes when incidents of deaths occurred, they slowed down. They started re-strategizing on a more effective, humane way of dealing with it. Some notable findings among users was that methamphetamine was driving internet fraud. So people, youngsters, were taking this drug because one effect is sleeplessness, and so they are up in the night so that they can walk across time zones, scamming people. That's one interesting finding. People used the drug surprisingly for weight control, and users kept evolving covert routes of accessing and using the drug. My important conclusion is that community structures and actors hold strong potentials in drug demand reduction, and understanding grassroots actors and engaging them could help develop effective drug demand reduction strategies. And I'm particularly interested because I have experience in the health systems, and one thing I discovered was that drug demand reduction is above primary health care in Nigeria. So it's not within the level of primary health care. And so when communities were responding, surprisingly, they were pulling primary health care resources to respond to. So those structures that were active in malaria control, in tuberculosis control in the communities, were the same people who came together to do something about drug demand reduction. So I'm advocating that in Nigeria, I don't know how the scene is in other places, but in our country, we should start thinking about getting the primary health care level involved in drug demand reduction. Yeah, and that's a citation of our systematic review where we found what works at community level for methamphetamine. Thank you very much.
Up next is Dr. Gladys Mutai Bett. She's a counseling psychologist who earned her master's in counseling psychology from Kenyatta University and a PhD at Kabarak University. She's a lecturer and student counselor at the University of Kabianga. She's a member of the Kenya Counseling and Psychological Association, ICU-DDR, and ISEP. Her publications focus on topics related to impact of alcohol abuse on individuals, families, society, and the role of guidance and counseling in managing alcohol and drug abuse. She's also a motivational speaker, consultant, and mentor. Gladys, I'll turn it to you.
So good morning. So I'm Dr. Gladys Bett from the University of Kabianga, and I am going to present on the role of guidance and counseling in addressing cannabis use among university students in the South Rift region of Kenya. So I wish to appreciate the NIDA and ICTDUR for actually sponsoring this study. I also want to appreciate my colleagues in their absence, Dr. Langat and Aspeti, who actually helped us to do this study. So as a form of background, we actually see that the latest World Drug Report indicates that around 269 million people use drugs worldwide, and that actually shows that the rate of drug use is increasing. So one thing that is also shown here is that the majority of the young people are using drugs, and most of them, research has shown actually that they do not consider cannabis use harmful, and that is why there's an increased use. Specifically, the Kenyan context is no different. a study by NACADA, the National Survey on Status of Drug and Substance Use that was done in 2022, actually showed that 1 in every 6 Kenyans aged between 15 and 65 years were currently using at least one drug or substance use. And the research actually showed that the number of people who are currently using cannabis is increasing. And I am, as student counselor, has been said. So guidance and counseling has been put in our universities as a professional field, which also has a broad range of activities and services that is aimed at assisting the individuals to understand themselves, others, and also the environment that they are in. So guidance and counseling is actually a profession. We use psychoeducation. We also try to do sensitization and many other activities in guidance and counseling. So we saw it fit to actually look at the role of guidance and counseling in actually addressing cannabis use among the university students. So a study by Gachua Kahuthi Kathu in 2012 in Kenya showed the reasons for youth using drugs, the reasons why they abuse drugs, and one of the reasons that came out very well is curiosity. They are so curious to know, what is this drug? You know, youths are people who like experiencing new things. So in the process, they actually use it to actually know what is it that they feel when they do it. Some of them are going through stress, and as a result, they actually look for something to sort out their stress issue. Peer pressure is also another factor that has come out so clearly because of the friends. They feel they want to fit in, they feel they want to be part of the group, and in the process, they start using drugs. Boredom is also another factor. In the university, there's a lot of freedom, so they feel that because they are bored, they want to actually use it. So others could be out of frustration or the fact that there is also availability of these drugs. So sometimes you also find it cheap, and because of that, they use it. So why did we focus on young people? One is the issue of freedom. They are in the university, they are outside of parental guidance, and because of that freedom, so sometimes they feel that they are now free. They can now make decisions on their own. But unfortunately, some of the decisions they make actually work against them in one way or another. Another thing that also made us to focus on these young people is that their brains are still developing. So when they start using drugs, how does it affect them in one way or another? Another thing is the fact that research has shown that actually there is a positive attitude on cannabis, especially the fact that they actually don't know the consequences of using cannabis and the fact that it actually leads to addiction. Peer pressure is also one of the factors that also made us to actually also be interested in this study, because these are young people with new friends in a new environment, and because of that, sometimes they also find themselves being into it because of their friends. And then there's also low retention rates in care and treatment. Going to rehabilitation and treatment is not very easy. So because of those retention rates, that is also one of the reasons why we are focusing on adolescents. And then curiosity and stigma, the fact that people don't come out to actually say what their problem is. So the role of guidance and counseling, as shown by this picture, is actually to help the students to achieve their potential. So through life skills training, giving them education, reproductive health. So guidance and counseling is actually a professional field that gives a broad range of activities. So we psychoeducate, we actually tell them about reproductive health, supportive environment, and then counseling is also part of them, and inspiration, as in we help these young people to achieve their potential. So we needed to see the objectives of the study. One was to investigate the prevalence of cannabis use among university students in the South Rift region, to find out the most commonly used forms of cannabis by the university students, and to find out the role of guidance and counseling in implementing evidence-based prevention, treatment, and recovery strategies. So the challenges that were found to actually be preventing and treating substance use disorders in rural communities were decreased access to primary care, so increased social stigma, lower perceived harm of substance misuse, decreased access to treatment and recovery. So in rural communities, there is actually decreased access to treatment and recovery because the rehabs and the treatment places are actually very few. So the methodology that was used in the study, so the research design that was used in this study was descriptive, survey research design. And the population of the study was 13,603 students, and a sample of 1,736 was used. The sampling procedure that was used was random sampling and purposive sampling for those who are using cannabis. The tool that was used is Cannabis Use Disorder Identification Test, and the data was analyzed descriptively, and it was also, the quantitative data was analyzed using thematic analysis, and inferential statistics was done through ANOVA and regressions. The findings. This study found out of the 1,736, the majority were male. That is 1,156, and 580 participants responded. The distribution according to the year of study, there was actually almost a similar 376 first years, 512 second years, 464 third years, and 384. Now, this study found out that many of the respondents had actually not used cannabis. That is the majority, that is 1,280. And then those ones who are using daily were a small percentage, that was 92. And then those who are using it 3 to 4 times a week are 102. And then those who are using it once in 2 weeks were 102. And also once a month is 160. So, and then the forms of cannabis that were used, mostly it was found that those who are using cannabis, most of them preferred to smoke. And then there were those ones who used sprays, others actually baked it or used it with cookies, and others through vaporization or vaping, and a small percentage using dapping. So when the role of guidance and counseling in addressing cannabis use, so a regression showed that guidance and counseling has played a role, a significant role in addressing cannabis use among university students in the South Rift region. So the challenges with effective treatment came out. A focus group discussion with peer counselors showed actually that the weak implementation of laws on drug trafficking, sale, and consumption may have actually contributed to the challenges in treatment. Another one, they also say that punitive laws on disciplinary of students actually was one of the things that found students hiding, because if you're found out, they would actually be expelled out of the university. So because of that, they actually hid and could not come out to say that they had a problem. Another thing that came out very clearly was rehabilitation centers were found to be very expensive. And sometimes for the few who are able to actually go there, some of them were not very effective. And then another thing was that prevention and treatment strategies and programs that have been put in place do not reach all the students. This could be partly because the students counselors are very few as compared to the number of students that are in the university. So the prevention and the treatment strategies that are being put in place do not actually reach all the students. And then also, the peer counselors felt that they are not effectively trained and actually prepared to tackle the drug menace that is in our universities. And lastly, it was also found that stigma affects treatment. So because people are stigmatized when they're actually known out to be using cannabis or when they're using drugs, so it is because of that they go hiding. And when they hide, they are not easily found out and helped before they work out. So this study actually concluded that the majority of the respondents were male, and many of them stayed in outside residence. So they were staying outside the universities. Majority of the students also have not taken cannabis. And for those who are taking or using the drugs, the majority cite smoking as the most common way of using cannabis. And it was also found out that prevention and treatment strategies have been put in place in the universities, but unfortunately it's only that it does not reach most of them. And finally, guidance and counseling has not really played a role in addressing the different forms of cannabis, but has shown to play a significant role in addressing cannabis use. So what are the recommendations made by the study? So one, multi-sectoral coordination for adolescents and young people actually need to be done. And this is where, at society level, the policies and guidelines should actually protect the young people and provide human-centered, rights-based approach. And then at community level, parents and community partners have a role to play in providing mentorship and guidance through sensitization and role modeling. And then in the organization, that is at organizational level, there is need to fight against drug use, but make it a collective responsibility, so that now lecturers, counselors, and all the facilities be actually leveraged to provide safe spaces for young people to receive information and services. And lastly, it was also felt that guidance and counseling needs to be strengthened so that the personnel who are working there be trained on assessment, prevention, and addressing of cannabis use. Lastly, it was also important to actually look at how to leverage on who we know the young people are. So it was also felt that there is need to engage young people meaningfully by providing the relevant skills and technical knowledge to engage meaningfully as peer educators, mentors, advocates, and also implementers who will actually result in programs that are more effective to them, are also responsive to their needs, and then would actually address the issues that are affecting them. And lastly, it is important to it was actually found that it was important to address the use of drugs, especially in primary and secondary schools. That is through policy and intervention, so that by the time they reach the universities, already this problem has been managed or at least reduced. Thank you. Thank you so much.
Thank you, Gladys. Up next is Dr. Valentine Ucheagwu, who holds a doctorate degree in psychology from Ebonyi State University, Azikiwe, with a clinical focus on counseling, psychology, and neuropsychology. His research interest is on finding affordable biomarkers for early diagnosis of brain impairment in Nigeria and, by extension, sub-Saharan Africa. He has done some studies on the neuropsychology of dementia and addiction, substance use and gambling. He's a senior lecturer in the Department of Psychology, Nnamdi Azikiwe University, Awka, where he is an associate director of the Research Center for Aging, Cognition, and Psychological Health. Presently, he's a deputy director of the Psychiatric Rehabilitation Center, Obosi, Anambra State, Nigeria. And he's also a fellow of the Global Brain Health Initiative, Trinity College, Dublin. Valentine, over to you.
For the kind introduction, thank you, ICUDDR, for the opportunity and the funding for this project. And thank you for the opportunity to present. What we did was to look at mindfulness-oriented recovery enhancement in reducing craving and improving cognition in persons using drugs in Nigeria. Just a preliminary investigation. We want to see the feasibility, or want to test the feasibility of using mindfulness-oriented recovery in a rehabilitation center in Nigeria, and possibility of extending that in sub-Saharan Africa. Over this conference, we've had prevalence of substance abuse in very many parts of the continent. In Nigeria, as of 2018, although there are many new reports now, but as of 2018, we have 14.4% of people between 15 to 64 years that abuse drugs. And over this conference, we've had so many prevalence of drug use. This by regions, people that abuse drugs in Nigeria. Of course, consequences of drug abuse has been shown to be physiological, social, economic, psychological, and spiritual. Our group in 2018 showed that there is persistent neurocognitive dysfunction, even 6 months following abstinence in people that have polysubstance abuse. So it shows that consequences of drug use still extend beyond 6 months following abstinence, particularly in neurocognitive structures like processing speed and the reaction time. So the problem statement is, in 2012, Nigeria brought out a national minimum standard for drug-dependent treatment. So treatment was tailored towards pharmacological and non-pharmacological interventions. But the question is, very few well-controlled randomized clinical trials have been reported. So our interest is to look at randomized clinical trial in Nigeria in terms of non-pharmacological intervention. Yeah, of course, there are evidence suggesting the efficacy of mindfulness in craving and cognition in global north, particularly in Europe and in North America. But this has not been reported in Nigeria to our knowledge. So our thought was to do a pilot study of mindfulness-oriented recovery enhancement using randomized clinical trial. In mindfulness-oriented recovery enhancement, what's important is we do mindfulness training. Following mindfulness training, we do cognitive reappraisal. Following cognitive reappraisal, then we do savoring. The difference between more and other mindfulness is that the mindfulness training in other mindfulness techniques ends with only mindfulness with concentrated breathing and some other techniques. But extension of here is that we also look at cognitive reappraisal, that is putting into consideration the cognitive behavior therapy in conjunction with mindfulness, and then look at the savoring. And when we talk about savoring, we are talking about readjusting the hedonistic principle in terms of ventral tegmental area and in terms of rewiring the top-down processing and bottom-top processing in drug addiction. So when you look at some literatures in more, you could find out that cognitive reappraisal and savoring makes mindfulness-oriented re-enhancement more appropriate. The aim of the study here is to test the effectiveness of this more in reducing cue-induced craving in polysubstance users, and to determine the effectiveness of this approach in improving executive function, working memory, inhibition, and set shifting in our sample. Because this is just a pilot study to look at the feasibility, can we do this really, before we now apply for a larger fund to establish this fund. So we looked at 20 participants, all of them were males, between 20 to 40 years. And they were polysubstance users that were admitted in Drug Law Enforcement Agency rehabilitation in Anambra State, Nigeria. Part of the instruments we used was cue-induced craving stimulus, and then electrocardiograph to measure the systemic blood pressure, diastolic blood pressure, pulse, and then the salivary cortisol. And then we also looked at the executive functions using the three executive functions we looked at was inhibition using the Stroop wet color test, then set shifting using the trail making test A and B, and then working memory using the number span test forward and the backwards. So this is just an example of cue-induced craving, which we've adapted for Nigerian use. That's the participants will look at this picture, and then after 3 seconds, the picture goes away, and he's asked to determine how reactive are you to this picture. And then the blood pressure, the systolic and diastolic blood pressure, and then the pulse are measured. At the end of the time, the salivary cortisol is taken, and then we proceed. Yeah, participants were randomly assigned to 2 groups. Group 1 received more, but because of the limited amount we have and then the limited time we have for this study, we just did only mindful breathing. We did not look at cognitive reappraisal and savoring. So we just did only part 1 of more, leaving the remaining 2. So the group 1 received mindful breathing weekly for 4 weeks, 20 minutes, in addition to treatment as usual, which they received in their center. And then the group 2 received only treatment as usual. We use statistics because this sample is very small. So first of all, look at significant difference, and then we now use multiple analysis of variance to look at the interaction effect. Ideally, no significant difference we are seeing for executive function and cue-induced craving between the more group and treatment as usual. Maybe because, and then the more group, Bett, however, did better compared to treatments as usual on some markers of cue-induced craving and executive function, but it was not significant at 0.005 level of testing. However, there are some interaction effects of mindfulness-oriented recovery enhancement and education on executive function, particularly speed of processing and set shifting. I'll just show you some of the results in graphical terms. So this is cue-induced craving. Although there are no significant difference, but then the people that had more had lesser systolic blood pressure post-intervention compared to control, though it's not significant at 0.005 level of testing. The same thing with diastolic blood pressure. And then the cue-induced craving, though not significant, but there are some differences between the pulse test, between the more and control. Now, the speed of processing, sorry, we didn't write the number, but then the red means the tertiary education, and then the blue means secondary education. Of course, in our participants, they are very educated between secondary and tertiary education. There are no people below secondary education. But then you can see that people with tertiary education did more or more than the control. So there's an interaction effect. The tendency that people with high level of education will benefit more from mindfulness breathing compared to people who had no secondary, who had no university education. The same thing with set shifting. But then we didn't find any other further interaction between inhibition, working memory, and then other neuropsychological examinations. In our discussion, we are saying that the pilot study demonstrated some indications of efficacy of mindfulness-oriented recovery enhancement on drug craving and cognition management using small sample population, although it may not be significant, like I said, at 0.005 level of testing. There is need to further this study with large sample population to also add the remaining 2 layers of mindfulness-oriented recovery enhancement, which makes more effective when we talk about cognitive reappraisal and then severing. And so we also want to add some level of experimental titration and those related implications to the baseline. Furthermore, we have to look at the cortisol baseline, which we did not present here. Limitations of this study. Small number of participants limited the power of the study. The time duration for more may have further accounted for limited differences we have observed because we just did only 4 weeks and only first part of the mindfulness-oriented recovery enhancement. And like I said, we only used one of the 3 full versions of more protocol in the study. Body scan, severing, and cognitive reappraisal were not included. We hope to do full more intervention in the future if we're able to secure funding from Fogarty, which we've already applied. Thanks for listening.
Thank you very much. Our final speaker is Dr. U. Venkatesh. He is working as an assistant professor at the Department of Community Medicine and Family Medicine at All India Institute of Medical Sciences, Orjiakor. He is identified as a national trainer of induction module community health officers to deliver comprehensive primary care at health and wellness centers under Bharat. He also does external consultancy with the National Health System Research Center, the Government of India. In 2017, he received the prestigious Indian Association of Preventative and Social Medicine Presidential Award. He's currently serving as the principal investigator of 4 ICMR research projects and an international project. As an investigator, he's working with the Global Health Advocacy Incubator, Hopkins, and ICMR. He's authored 3 books on public health topics and won many research awards both nationally and internationally. He has published several publications in various national and international journals and is affiliated as a reviewer. His area of interest is community-based primary healthcare implementation research. I'll turn it over to you.
Dignitaries and delegates present here. And first of all, I'd like to thank ICUDDR and NIDA for the support. So my study titled Determinants of Substance Use Among Young People Attending the Primary Healthcare Centers in India. So starting with the introduction, the substance use includes misuse of prescription drugs, the use of tobacco, alcohol, illicit drugs, and the use of injection drugs. Around 5.5% of the global population aged between 15 to 64 had used substance use in 2017, and about 35 million people are estimated to be affected by the drug use disorder. Though alcohol is the most common substance used worldwide, the tobacco is highly prevalent in India. And most of the studies, including the National Health Survey like NFHS, are restricted to the tobacco and the alcohol in the domain of the substance use. However, the estimate of other substance in the national level setting was unavailable. And the onset of the substance use, and particularly in the early stages of life, can lead to dependence in adult life and affecting the psychosocial behavior and quality of life and damaging the physical health and manifest mental health problems as well. So understanding the factors that contribute to the substance use might help in developing these targeted prevention strategies, which can reduce the likelihood of individuals starting to use a substance in the first phase. So with this background, our objective was to estimate the prevalence and determinants of substance use among young people attending the rural and urban primary healthcare centers in India. Starting with the methodology, so it is designed as a multi-centric cross-sectional study across 15 states in India from March to October 2022. And these participants were young people, that is defined as 10 to 24 years of age group, attending the rural or the urban primary healthcare centers of medical colleges. One medical college from each state was chosen. We used consecutive sampling technique to enroll the individuals. So those who fulfilled our inclusion criteria, so we enrolled them till we achieved the targeted sample size. We used the WHO assist tool in the clinical settings. We choose this tool because this is primarily meant for the primary healthcare settings. And secondly, the regional languages, I mean the different Hindi language, Hindi and other local languages of India was available. So we had a validated tool available with us. So the substance use score was calculated individually for each substance among users and divided into the different grades, that is grade 1, grade 2 or grade 3 as per the assist guidelines. The sample size, which was calculated using the EpiInfo version 7 and considering the NFHS 5 data for the tobacco use, that is 42.7% with 95% confidence level and 5% of the confidence limit. The calculated sample size was 376, and accounting for the design effect, considering the multicentric study across the 15 states, the calculated required sample size was the 1504. The data analysis was done using the SPSS, and binary logistic regression analysis was done to quantify the association between the substance use and the determinants. The ethical clearance was obtained from the primary institute, that is the AIMS Gorakhpur, and all other 15 sites which we chose before collecting the data. So coming to the results, so this is the prevalence, the distribution distribution of the substances. The prevalence of the substance use was 32.8% at the primary healthcare level in India. The median age of substance use was 22. The median age of starting the substance use was 18 years. Among the substance use, 24.6% had started using below 15 years of age, and 75.5% started before completed the adolescence, that is the 19 years and less than 19 years. The Mizoram had the highest prevalence of the substance use. As you can see, the northern east region of the countries had the higher prevalence, and Kerala had the least substance use prevalence. So this is the prevalence of individual drugs use and level of substance involvement. So as you can see, the most prevalent substance was the tobacco, then followed by alcohol, then we have cannabis, then opioid. Then we have a severity score as well. As you can see, we will discuss in the coming slides. So this is the table number 2, which actually is showing the determinants of the substance use. So we compared this, the prevalence of the substance use with the various socio-demographic profile which recorded. So as you can see, like I said, we used logistic regression analysis. So we can go by the adjusted odd ratio. So we wanted to see how this factors independently determine the use of a substance. So this odd ratio can be interpreted like, for example, 1.7. It means the one, if you are the 20 to 24 years of age, the 1.7 times of being the substance use as compared to 10 to 19 years. So 1.7 times higher if you are for 20 to 24 years. As far as gender is concerned, it is 4.6 times. As far as the family type, residence and marital status, it was only the residence, that is the urban area, found to be significant with odd ratio of 1.7. Now, coming to the family history of substance use, here the odd ratio was 3.3, and similarly, we stratified the different geographical region into the northeastern states and the other states, and the northeastern states having the odd ratio of 6.6. As far as the employment status is concerned, we compared with those who are studying, and we found 3.9 odd ratio those who are employed at the age below 24 years of age. Coming to the socioeconomic status, the odd ratio was found to be 2.7 for the lower socioeconomic status as compared to the higher, upper one. So this is the table number 3, showing the knowledge about the accessibility to the individual drugs. As you can see, the most of the people are well aware. Very few, that is 6.8% of the people were not awareing the access to the tobacco, and 15.9% were not aware the accessibility of the alcohol. And the overall means these for the other substances, around 70% are of well aware about the accessibility of all the drugs. Then comes the severity score. So we also found out the determinants for the severity. So severity we classified into one category as moderate to high, and another one is low involvement in all substance use. So here we found the marital status found to be very significant with odd ratio of 12.5. So those who are divorced are 12.5 times higher, being the moderate to high involvement in the substance use. Then those who are employed at a very early age were having the odd ratio of 8.5, and those who are not employed and not currently studying were having the odd ratio of 5.8. So the study concluded about 1/3 of the people were using substances, and among them 2/3 had started these substances before they completed their adolescence. If you look at the determinants of the substance use, they were male gender, belongs to urban area, family history of substance use, and particularly if you are belonging to northern eastern states, employed youth, and belongs to lower socioeconomic status. If you talk about the severity, that is the high and moderate substance involvement, those who are employed at in the youth, followed by unemployed and not currently studying, divorced, followed by unmarried. So this underlying determinants of substance use can help in developing targeted prevention strategies and designing more effective treatment and rehabilitation program. Thank you so much.
Perfect. I'd like to thank all the speakers for their great talks. We do have a few minutes for question and answer, so if you have a question for any of the speakers, please raise your hand. I can bring you the mic.
Thank you so much, all of the presenters, for your presentations. Those are very great and very interesting. I would like to have a question for Dr. Stephen. The findings are very interesting, and can you please talk a little bit more about the positive impact that's shown in the result table? And also the epidemic and pandemic impact inventory, you reported the alpha score. So was that in your country, or it was from the previous research?
Thank you for the question. The first question on positive impact. I think after COVID started, everybody seemed to look at the negative side, but we also experienced people who were flourishing in that time. In the country, if in Kenya, if we look across different populations, like children reported having enough bonding time with the families. So as the lockdowns were happening, children were happy because the parents were at home. And that then goes to other populations, like those who are in treatment centers. Some of them, after being discharged to go home because of the lockdowns, they connected with their families. They had quality time with their families. And as I started saying that Kenya is a collective society, that could have explained why there was a positive impact in the population that we looked at. The COVID scale, the COVID impact scale that we used, the alpha that is reported is actually for that specific population. It's not for the other population, it's for that specific population of people in treatment that we carried the survey on.
The second question was about the epidemic and pandemic impact inventory that you use in your as an instrument in your research. Was that validated in other countries or in your country? The alpha.
Oh, it's originally developed in the United States. It had been validated there, so we were trying to use it on a different population from the United States, and that's why we also ran our own alpha in our own country.
So that is the alpha score in your study?
Yes.
Okay, very good, thank you.
Hello. I am Dr. Ucheagwu from Abila University in Nigeria. I really want to commend Dr. Orjiakor for this presentation. Very beautiful work. And incidentally, what he did here was what we did in our poster, which is out there. I'm a sociologist by training. We usually ask ourselves, why is this happening? He has told us so much about the effect of, we call that drug mate. In Igbo, I call it Mpurumini. That's how it is called in Igbo. Mpurumini, that's the name is given. So we did the poster presentation of that. We never knew we had the similar focus. In our own focus on why was this drug taken in Nigeria, why was it taken in Eastern Nigeria? So I want to commend him for a beautiful job well done. Orjiakor, I'm grateful. Thank you for the beautiful job well done. Thank you.
Okay, thank you. My name is Dr. Wisdom Krokei from Niger Delta University, Nigeria. I want to thank all the presenters, but a very brief question to, I've forgotten the name. Her name? Gladys, yes. Thank you first for the presentation. And secondly, while you were making your presentation, something caught my attention. You studied the population of 13,603 persons, right? And you have the sample size of 1,736. My worry is how did you arrive at that 1,736 and what sample size technique did you use in getting that?
Okay, thank you. Thank you. It was calculated using the sample size was actually calculated using one of the, sorry, I have just forgotten the name, but it was calculated, and then I got a sample size of 1,950. And then, okay, so when the questionnaires were distributed, so those who were able to actually bring in, it was 1,736. So sorry, I have just forgotten, but I will Google and then let you know. It was calculated. Thank you.
Okay, I guess you must have used Taro Yamane, I don't know. Because I quickly look at it and then I use the Taro Yamane formula. And if you use that, we arrive at 388 point something by approximation, you are supposed to have 388.6. So if that's the formula you use, then the data sample size is quite confusing to me. Anyway, if you Google it, I will still meet you later to know that. Thank you.
I will get to you later. Thank you.
I would like to have a question for the final presenter. So in the findings indicated that one of the determinants of substance use were employed youth, and some people from the northeastern state and also window participant, right? Can you please talk more about the implication from these findings? Because I found it very interesting that the employed youth that tend to use drugs more than unemployed youth, right? Thank you.
Yes, you rightly pointed out. Particularly, the determinants is targeted to the particular specific population, that is the youth who belongs till the age of 24. So if they are having the early employment and at the same time the education level is also low, and considering the easy accessibility to the drugs and various other factors which are locally relevant to the states, for example, some cultural factors and peer pressures, all those things contribute for the beginning of the substance use in the northern eastern states.
So that means because they have early incomes and accessibility to drugs.
Yes, and we can have a separate analysis for those states. Here, our aim was to find out the determinants for overall India, but we can have a separate analysis and stratifying the northeastern states and the other states and find out the determinants for particularly for this northeastern states. That separate analysis can be done, including other local factors, considering other local factors which can also contribute to the initiation of the substance in the region.
Thank you.
That
I think
can
it's
be the
very
future study.
important. Yeah, thank you.
Okay. My name is Ejikeme Bishop Sogweji from Reclaiming Futures. My question is to Dr. Orjiakor, and I will want to first of all commend you for that effort, because methamphetamine, as we call it, mkpụrụ is really a big issue, especially among young people in Nigeria. And during your presentation, you mentioned that there is a need to engage the primary health care in addressing the issue of methamphetamine. But I want to ask, what advice or recommendation do you have for family engagement? Is there any recommendation how parents or the family can be engaged? Because this issue affects the families directly. And a lot of children from those families, a lot of parents that have children who are using that substance are really looking for how they can address it. So do you have any suggestion or recommendation for that? Thank you.
Thank you very much, and thank you for everybody who listened. Why I think the primary health care is key or very important for us to consider, especially in Nigeria, is because every community has one. And so it's everywhere. The public health facility, the public primary health care centers are everywhere, so easily accessible. We have international partners already there, UNICEF, WHO, actively operating in these centers. The government is aware of them. Even the local government is well aware family programs are running there already. And so it's a center where the families are already conversant with. So it's close to everybody. Right? So I think if we can begin the advocacy for addiction management at that level, I mean, I know we have manpower problems, like human resource problems, particularly specialists in addiction programs are not so conversant with the primary health care in Nigeria. But if we begin this advocacy, I think we can reach almost every family. Thank you.
Sorry.
Hi, I'm Dave Corlati from UC San Diego. I just wanted to say I thought all these projects were absolutely fantastic. I'm just curious if this is a program that NIDA will continue to sponsor, and if so, how do we get more applications to you guys?
We are hoping to continue this project down the road in collaboration with ICU DDR. So you can subscribe to the NIDA International Program e-newsletter. We'll publish any openings for submissions, that sort of thing, down the road. So yeah, no current dates pending, but definitely hoping to continue down the road. They were great presentations. I want to thank all the presenters once again. We are at time. Thank you everyone for attending and for your great questions. This was a really great session, so thank you.